Thank you very much, Gil, and the AIBD organizers for this kind invitation. So I was tasked to talk to you about recent and emerging therapies for ulcerative colitis, and Gil provided you a background that we're going to build upon in the next couple of talks, as you will see. These are my disclaimers. I had a disclaimer about using brand names. This has been deleted since I removed the slides about biosimilars. So starting with some questions for the audience. Anti-TNF agents are the most effective therapeutic options in patients with moderate to severe UC. If you would like to answer now, you can. Otherwise, we have the same questions at the end. I don't think this is in the ARS. Okay. Tofacitinib, a non-selective JAK inhibitor, can reduce stool frequency and rectal bleeding in patients with moderate to severely active UC as quickly as, and the options there are. Okay, perfect. So I was told that we can skip the questions and go to the presentation. So this is the presentation. You all know the answers already. So over the next 20 minutes or so, I'm going to review the emerging evidence regarding currently available and approved therapeutics for ulcerative colitis, discuss treatment selection in patients with mild to moderate UC, and look at some emerging therapeutic options for patients with ulcerative colitis. So Gil already spoke about this. This is our old approach to IBD in general and UC in particular with its fallacies, right? It was a reactive approach, symptom-based with short-term goals. The fail-first strategy was really a fatal flaw for any IBD patient, but particularly for Crohn's patients because of the progressive nature of their disease. And then really, when you think about it, clinicians were generally using biologic agents in the order they came out. I grew up with agent A in fellowship. That's what I'm going to use as a first-line agent, regardless of other evidence regarding efficacy and safety. So that was wrong. This is how we're trying to do things today. We're looking at inducing response faster, so being more efficient, being more effective. We're looking for deeper levels of response and remission, trying to personalize, optimize, and keep safety in focus. So this is the playing field, today's playing field for UC. Of course, we know 5-ASA agents are effective for mild moderate disease, both induction and remission. Steroids, induction only. Thiopurines, maintenance only. Methotrexate, neither. Anti-TNF, vedolizumab, and tofacitinib are effective for both. And off-label, but upcoming likely, ustekinumab, and of course, off-label also cyclosporine. So what's relatively newish in the mild to moderate field of UC? So this is budesonide delayed extended release for induction in mild to moderate UC. This is a study, if you will. It's a placebo-controlled, but it was a comparative study because patients were allowed to continue their baseline mesalamine. They're considered mesalamine failures. And budesonide was slightly more effective than placebo, so to speak, or control group as far as the primary endpoint. It kind of squeaked a statistical significance with a P of 0.049. But the signal is there across the board. So remission, endoscopic improvement, and histological healing, at least as far as this trial goes. In another trial where patients were actually forced off mesalamine, budesonide was a bit better than placebo, but as you can see, budesonide MMX was not statistically significant from regular budesonide. Take-home message here is in patients with mild disease, especially the ones you want to bridge off regular prednisone, you can use either form of budesonide. I do that in my practice because they seem to be equivalent, and of course, the cost here is substantially less. So thiopurines, azathioprine, and 6-MP not effective for induction. We know this from a small meta-analysis published several years ago, but it is fairly effective for maintenance of remission in patients who are steroid responders. Same meta-analysis, small numbers, different standards than what we use nowadays. In contrast, methotrexate not effective for maintenance of steroid-free remission. 2 large randomized trials, one from Europe, one from the United States, both negative, both with sort of a similar endpoint of maintenance of remission in patients who are steroid responsive. And this is the result of the study sponsored by the Crohn's and Colitis Foundation. Virtually no difference in the maintenance of remission rates in patients who are induced with steroids. So this is what the treatment landscape looks like today. It's pretty barren. We have 3 categories of drugs: anti-TNF, anti-integrin, and JAK inhibitors. What's new about anti-TNF? Not much. This is a very primitive comparative analysis, absolutely not direct head-to-head, but this is what we call a normalization or comparison by normalizing the placebo rate. So you're trying to bring the placebo rates to the same level across trials. And if you look at similar time points similar endpoints for similar time points, the anti-TNF agents kind of look the same, allowing for substantial differences between these trials. So infliximab, adalimumab, golimumab, eyeballing cross-eye look about the same. Of course, we have vedolizumab, Gemini 1, effective for induction, but especially maintenance of remission. So these are drugs that look great long-term. Week 52, remission, sustained response, durable sustained remission, endoscopic improvement or mucosal healing, and steroid-free remission. A little bit of a dose dependency there as well. Tofacitinib, the newest kid on the block. This is a JAK inhibitor, also very effective for induction, so remission at week 8 and maintenance remission at week 52. In both cases, so about 30 to 40% of patients in the vedolizumab trials were anti-TNF exposed. A little over half of patients in the tofacitinib trial, so this is the OCTAVE program, were anti-TNF exposed. So these are pretty tough hombres, and results are very good, again, for both induction and maintenance therapy. A little bit of a dose response there that panned out mostly in patients who are bio-experienced. Same thing. So this is the mucosal healing. On the left side here, you have early responses, so week 8, and then maintenance of mucosal healing, week 52. Both doses, both 5 and 10 milligrams twice daily, were superior compared to placebo. And then you have the rapidity, right? So tofacitinib, and that may end up being a class effect, works very, very quickly. This is a sub-analysis of OCTAVE 1 with tofacitinib. And as you can see here, these are patient-related outcomes: stool frequency, rectal bleeding. In both cases, the results became, or the difference became significant as early as 3 days after starting. So these guys are rivaling steroids. So how do we choose the right agent? Well, as Gil said, the AGA pathway provides some guidance in this regard. This is for ulcerative colitis. Stratification based on risk. What's the risk with UC? Obviously, colectomy. So who are the high-risk patients? In addition to having severe symptoms, are those who have extensive disease, severe disease, deep ulcers, and are relatively young, at least younger than me. Patients who have high CRP and low albumin are poor responders to biologics. We really don't know how are they going to do with small molecules, but these are good predictors of poor response to biologic therapy. And then, of course, patients who are steroid refractory, hospitalized, or co-infection have poor or worse outcomes. In contrast, the opposite is true. So our patients are low risk if they have limited disease, mild disease, or normal CRP. So do the AGA guidelines help? Or they kind of leave you in limbo, right? They put biologics all on the same platform, vedolizumab, anti-TNF, kind of the same, whether you're responding to steroids, steroid refractory, or you failed thiopurines. And even if these are relatively new, they're only 2-3 years old, there's no tofacitinib. So these are outdated. We were just talking to Dr. Valentine earlier. In order to make these applicable, you really have to develop an app because it's going to be updated every 3 months from now on. So the AGA acknowledged the lack of comparative data. What do we do when we don't have comparative data? Well, we try meta-analysis. Standard meta-analysis don't help you because the studies are too heterogeneous. So investigator smart people have come up with these so-called network meta-analysis or smart meta-analysis, which use complex statistical modeling to try to compare between trials. So if you have a trial of drug A versus placebo and drug B versus placebo, they claim that they can compare drug A versus drug B. So indirectly, you get a virtual clinical trial, a virtual comparative clinical trial. And this is one of them by Dr. Siddharth Singh here in the audience for ulcerative colitis, moderate to severe, bio-naive population. Based on this, the best first-line agents seem to be infliximab and vedolizumab, with everything else falling on as a second line. For patients who are bio-experienced, so anti-TNF exposed, induction of remission, here Tofa basically dominates the field. So were they right? Well, we finally have the first comparative head-to-head trial of 2 biologics, the Varsity trial, large size, almost 800 patients, standard dose, about a quarter, failure of anti-TNF therapy. These were kind of pushed mostly towards vedolizumab, still a little bit of a bias, and no dose escalation. So Gil already showed you these results, and vedolizumab was superior for clinical remission and mucosal healing at week 52. So this is now undisputed evidence. What's the problem with these meta-analyses? Well, they're not perfect, no matter how smart they are. So I'm just giving you an idea about, this is bio-naive patients only, and I extracted the data from the oldest pivotal trial with infliximab. Obviously, everybody in ACT was bio-naive. And the newest, OCTAVE, with Tofacitinib, I just collected the patients who were bio-naive from that trial. So this is sort of a comparison between the two of them. As far as disease severity, more patients on Tofa had pancolitis, CRP was higher, more of them were on immunomodulators at baseline, and these had to be stopped. In the infliximab trials, they were allowed to continue. Remission was rectal bleeding 0-1, here was 0. No central reading, yes central reading. The only thing that favors Tofa in this comparison is that this was remission in remitters, so it's a little bit easier to achieve versus remission in responders. These are the results down at the bottom. So I'm not ready to buy the idea that infliximab and vedolizumab are really better than Tofa. I think we need a head-to-head trial about that or for that. But that's just sort of to put things a little bit in perspective. So no, we need comparative trials, basically. How about acute severe UC? For bio-naive patients, of course, we have infliximab, cyclosporine, Tofa. These are all off-label, if you will. Anti-TNF experienced, cyclosporine, and maybe Tofacitinib. So what's new here? Well, kind of not the return of the Jedi, but the return of cyclosporine. This is emerging data, 2 different centers. So we have the French group, and then we have the University of Chicago group. I just took out patients with ulcerative colitis from these 2 studies, cyclosporine or tacrolimus for induction as a bridge to vedolizumab maintenance. These were patients who failed anti-TNF drugs, so those are completely out of question. And the results look fairly promising. 68% colectomy-free, 45% colectomy-free while maintaining vedolizumab. So it's an interesting part, and I think it's a new paradigm, and I'll tell you why in a second. So we brushed off the cyclosporine books in our practice. It's about a patient that I had 2 to 3 years ago, acute severe UC. This was at the time he was hospitalized, or day 3, and this is 10 weeks later. Of course, not complete mucosal healing with cyclosporine and vedo, but here's the difference. He was on 60 milligrams of prednisone here, 0 here. Even if you send him to surgery, this is a much better patient compared to the one who's on high-dose steroids. So this is my view of treatment for UC as of today. Of course, for moderate to severe patients, vedolizumab should be first line or first choice based on the emerging data. Patients with mild moderate, you can go into a step-up fashion from 5-ASA to steroids. And then patients who have more severe disease or fail vedolizumab, infliximab, tofacitinib, and cyclosporine. Principles: severity-based individualized therapy. You dance with the girl that brought you to the ball, so maintain the agent effective for induction, monitor, optimize, and risk mitigation. Half of what I told you today is going to be different in 3 years. So budesonide, in summary, is modestly effective for mild moderate UC. Thiopurine is not effective for induction, but effective for maintenance and steroid-responsive UC. And methotrexate not effective for UC. Vedolizumab, first-line therapy for patients with moderate or moderate to severe UC. Infliximab and tofacitinib should be first line for patients with severe UC, and calcineurin inhibitors may be used as rescue therapy in patients with acute severe UC. So now in the next 10 minutes, a glance into the future. So this is how the therapeutic field, if you remember my first slide, this is my 2025 therapeutic slide. All these are independent agents. Nothing here is a biosimilar, just to give you an idea. So in addition to, the only thing that field is not moving is anti-TNF. That's kind of over. But everything else is expanding. So anti-integrins will have additional members, interleukins. This is huge expansion here, and we have likely new interleukins like IL-36 inhibitors. The JAK-inhib field is expanding, and we have a completely new class of drugs called S1P receptor modulators. So this is, first of all, good news about old friends. So injectable vedolizumab, effective as intravenous vedolizumab for moderate to severe UC. This was just presented at UGW. A significant difference between both arms, so sub-Q or IV versus placebo. And I put here the Gemini 1 data is nearly identical to what we had in the registration file. So this is now awaiting FDA approval. And then we have other trafficking inhibitors, of course, related to Vedo. So first off, Vedo is an alpha-4 beta-7 inhibitor. There is a beta-7 inhibitor, which basically blocks not just the adherence and the traffic of activated lymphocytes into the tissue, but also they block the adherence of these activated lymphocytes to the epithelial cells, or their tissue traffic inhibitors. Etrolizumab is one of those, so anti-beta-7 for moderate to severe UC. This was already reported, the phase 2 data, a few years ago. Nice dose response and time incremental dose response. So just like all trafficking inhibitors, they tend to keep working over time. And this is now in phase 3, very large phase 3 program, likely to come out at some point. Abrilimumab is a me-too for vedolizumab, so it's alpha-4 beta-7, moderate to severe UC, just published in Gastro. Remission and mucosal healing, both significantly different between drug and control group, also with a dose response there. And then we have the mirror image, if you want, of a drug like vedolizumab. So alpha-4 beta-7 has to interact with MadCAM. Or adhesion molecules on the surface of endothelial cells in the gut. So these are gut-homing lymphocytes attaching to gut-based endothelial cells. So if you block this, you theoretically should have the same phenomenon, and that was proven as a proof of concept a couple years ago with this drug, who was effective, also with a dose response and a little bit of a shoulder. Some interesting factoids about this. This has changed hands a few times. It used to be a Pfizer drug, then Shire drug, and now it was purchased by the same company that makes vedolizumab. So unclear future. This may be cannibalized or sold, but it is a proof of concept, and it may be replicated in the future. The IL-23 inhibitor pipeline is very rich. And we're moving from sort of a crossover, so blockage of both IL-2 and IL-23, to selective blocking of IL-23, because people realize that blocking this probably has not much of an additional effect. Ironically, the drug, ustekinumab, was developed only in the idea of blocking IL-12, and by chance we figured out that there was another interleukin that was blocked along the way, and this became the primary mechanism of action. Half of what we do is chance. Just think in mind penicillin if you want. So ustekinumab, induction in moderate to severe UC. This is phase 3 Unify, already presented at ACG. Significant difference there between drug and placebo. Not much of a dose effect, interestingly, for UC. And then the maintenance data was presented at ECHO last month. Obviously, significant difference from placebo among responders. So this was also submitted to the FDA. Mirikizumab is a selective anti-IL-23 for induction of remission data here. Again, nice dose response, significant difference from placebo. This is moving to phase 3 studies. JAK-STAT, this is going to see an explosion over the next few years. This is obviously small molecules. The nice thing about the JAK-STAT pathway is that can be tailored due to the dimerization of these kinases. So you can really make it whatever you want, and that's the beauty of JAKs. So, of course, Upadacitinib for ulcerative colitis. This has been in the news. This was published at UEGW last year. Ulcerative colitis, induction, so week 8. Very significant difference between UPA and placebo with a nice dose effect. It's just draw your attention here. As we're increasing the veracity, the rigor of the endpoints, placebo rates are basically buried into the ground. It's one of the few where you had 0 response and remission at week 8 in the placebo arm. And then a new class of drugs, this is the S1P receptor modulators. You can think about them as being trafficking inhibitors at the lymph node level. So T lymphocytes, in order to promote inflammation, have to travel and migrate into the gut tissue. Where are they coming from? They're coming from lymph nodes. So they're trained in lymph nodes. They're told, go to the gut and cause trouble, and that's what they do. But in order to exit the lymph node, they have to smell their way out. And it turns out that S1P, sphingosine-1 phospholipid, is basically the gradient, much like a salmon smells its way up the river to spawn. Basically, lymphocytes will smell their way out of the lymph node based on the S1P gradient, get into the circulation, and get to trouble. So these agents basically plug the nose of lymphocytes. The lymphocytes can't find on their way out, and they remain trapped in the lymph nodes. So lymph node trafficking inhibitors. Ozanimod is kind of the earlier of the drugs in this class, moderate to severe UC. This was presented already. Response and remission statistically significant, and the maintenance data will be out. The phase 3 program was completed, so this will be submitted at ADW. And etrasimod is a bit more selective than ozanimod, even fewer side effects. First of all, this is a very safe class of drugs. Overall, being trafficking inhibitors, to some extent, they replicate what vedolizumab does. So significant differences between the larger dose, so 2 milligrams versus placebo, as far as all primary and secondary endpoints. So this is moving into phase 3. So the future likely will be a duel between small molecules and biologics. And if you look at this chart, it's hard not to see some dominance here. So the efficacy is going to be there. Right now, the safety looks better here because we only have traffic inhibitors. But with the advent of S1P receptor modulators, I think this will turn out to be fairly equivalent. Everything else, these guys dominate. I mean, there's no immunogenicity. You can combine them. They're convenient, interchangeable. You don't have to worry about generics, biosimilars. These are very simple to do. And in the future, they can be made, obviously, very cheap once they become available in biosimilar fashion. So this is my view of the treatment for UC, not too very far horizon. I think first-line agents will become, or we'll see small molecules becoming first-line agents for UC. Moderate to severe will have the S1P modulators, and severe disease will have JAK inhibitors as first-line, whereas anti-TNF, anti-integrins, IL-23 will become second-line agents. The other thing that's probably going to change is we may get rid of steroids. JAKs work so fast that you probably can get by without steroids, especially since you will need a maintenance agent anyway later. And this is the other thing. I think we need to figure out targets, predictors of response to each class. We're going to have 23 drugs in 6 years. You can't just go blindly about which one to pick. I think we'll also see stage therapy, so no more maintaining with the same drug that you induced with. So I think you'll be able to induce with one drug and maintain with another because you're not going to be afraid of losing response or immunogenicity. And because there is a ceiling for efficacy today, we may have to resort to a combination of mechanisms. So identifying the goal of therapy, as Gil said, very important. Clinical, biochemical, endoscopic. What's our endpoint? Which drug of the over 20 based on mechanism and host factors? We have a ceiling of response and remission. The only way to beat that, I think, is by combining therapeutics. And then we'll see more of this de-escalating therapy, healthy switches, somebody who's doing well being switched to a different class for a variety of reasons. So in summary, rich pipeline of drugs, most likely will hit, most of them will hit the market. We'll see changes in treatment paradigm and algorithm. The focus in the next decade should be on personalizing therapy, synergism, and optimization. And that was my last slide. Thank you very much.